ago, a witty public servant made a remark that seems to get more relevant every day. The official said, "Everyone is entitled to their own opinions, but not their own facts." When it comes to the endless debate about healthcare costs in the US, there is no shortage of opinions about why it costs so much. And there are loads of theories about why healthcare spending per capita is nearly double in the US what it is in other similar economies around the world. But what makes this question so vexing is that all of these opinions and theories seem to come with their own facts. Many experts believe the basic reason for higher healthcare costs in the US is overutilization of services. They have numbers to prove it. Others blame underinvestment in social spending. They have numbers too. Still others believe the basic problem lies with the healthcare workforce. Too many specialists, not enough primary care physicians. Do they have numbers to prove their theories? Of course they do, and often the data is quite good. But in many cases, this data seems to exist in a vacuum, without a broader context to make it meaningful. Like, how do metrics in the US compare to figures in other countries? So I decided to take a comparative approach. I wanted a more data-driven and nuanced understanding of all factors driving healthcare costs. And so where do you begin? I decided to look at 10 other countries who are high spenders in healthcare. Fortunately, there was plenty of existing data to draw on from sources like the Commonwealth Fund and the OECD. The OECD, that's the Organization for Economic Cooperation and Development. 36 member states, mostly European, but also the US. First, I wanted to look at things like healthcare spending. I wanted to see how the US stacks up across the other countries. I wanted to get a sense of how much expenditure comes from private sources and public sources, and what proportion goes to inpatient, outpatient, and long-term care. Then I wanted to look at how much things like labor cost and other inputs. And then to look at things like access to care, quality of care, and utilization rates. And finally, to get a sense of how that spending translates into what we care about most, health outcomes. So big picture first. What does the US get for the extraordinary amount of money it spends on healthcare? Are outcomes better? Do people live longer? Are they more likely to survive after an operation? Well, the picture is mixed. On the downside, US life expectancy is 78.6 years. That's 2 years less than the OECD average. And recently, life expectancy in the US has been declining. And when we take into account levels of ill health in the population, the US looks even worse. Countries like France and Switzerland have fewer deaths in their populations from causes where timely and effective medical care can save lives. On the other hand, the US has excellent acute care and deploys the latest medical technology in ways that can have a meaningful impact on people's lives. So while Americans are more likely than their counterparts in other countries to have a heart attack, they're also more likely to survive after treatment. And the same is true for stroke. So now that I had a baseline for outcomes, my team and I decided to turn to all of those popular theories about what's driving healthcare costs and see how well they held up to the data. We started with utilization. Many people believe Americans overuse the healthcare system. Many people believe US doctors run up costs by practicing defensive medicine, that they prescribe unnecessary tests and hospitalize people who don't really need it just to avoid a lawsuit, that the fee-for-service payment system incentivizes overuse. But what does the data say? Taken as a whole, the US is about average. That means way above average on certain things, like the number of MRIs, above average on others, like the number of knee replacements, and below average on things like the number of visits to the doctor or the number of hospitalizations per year. Next, we looked at social spending. Would the US spend less on healthcare if the government invested more in social spending? This too is a popular theory in some quarters. It sounds reasonable, but the data suggest otherwise. First, the US actually doesn't spend that much less on social spending than other countries. The The US spends 16% of their GDP on social programs. The OECD average is 17%. Second, there appears to be a positive relationship between healthcare spending and social spending. That means that the more a country spends on social programs, the more they spend on healthcare. Why? Likely because if you're a country that values spending on something like healthcare, you also value spending it on education and housing. Now we come to the narrative about over-specialization. The argument runs that if the US had a better ratio of primary care physicians to specialists, patients would be more likely to go see their primary care doctor instead of going to see the specialist, which costs more. But here, this hypothesis also runs counter to the data. When we look at the total number of doctors within the country, we find that per capita, the US has fewer numbers of physicians than the OECD average. And the story is similar for nurses. When we look at the breakdown of primary care physicians to specialists, we estimate that about 57% of doctors in the US are specialists. That's about average as compared to a group of similar countries where we could get comparable data. So for a country that spends so much on healthcare, the overall number and mix of doctors and nurses looks pretty similar to other countries. What about administrative complexity? The US has a highly fragmented system, 880 private insurers, with about half of spending coming from private sources and the rest from public sources. This means that providers have to deal with different sets of benefits and different levels of claim denial risk. And of course, 880 different sets of forms. Could this administrative complexity and fragmentation explain some of the difference in healthcare spending? The answer depends in part on how you define the cost of administration. The OECD estimates that about 8% of healthcare costs go to administration. That's more than double the percentage spent in other high-income countries. For example, countries like Switzerland and the Netherlands spend half as much on healthcare bureaucracy, despite also having insurance-based systems. And when we take into account indirect costs, like time spent, we estimate that 30% of every healthcare dollar in the US goes to administration. The exact figure depends on exactly what's included, but either way, the US spends a lot more on administration than other countries. But can administrative costs all alone explain the difference between OECD costs and US costs? No, it cannot. 15 years ago, a well-regarded US economist, Uwe Reinhardt, echoed the Clinton campaign slogan, "It's the economy, stupid." Uwe announced that if you really want to understand why healthcare costs in the US are so high, it's the prices, stupid. Now, to a non-economist, this might sound like circular thinking. High costs are the result of high prices, a bit like saying rain is caused by precipitation. Aren't they all the same thing? Prices, costs, rain, precipitation? Well, I can't speak for meteorologists, but to an economist, no, they are not the same thing. Cost is the amount of money it takes to produce a good or service. Price is the amount the seller decides to charge, forcing the buyer to pay that amount. The buyer has no control over cost. The seller may have some control over cost, but has a lot of control over price. So when economists say high costs are the result of high prices, what we mean is buyers have to pay a lot because sellers are in the position to charge a lot. So how does all of this translate into data when we look at costs and prices in US healthcare? It probably won't surprise you to learn that across the board, the US has some of the highest prices for medical goods, services, and labor. Drugs, of course. Crestor, a cholesterol-lowering drug, costs $86 in the US. That's more than double what it costs in other similar countries. US prices are higher in other categories as well. US primary care physicians are paid just over $200,000 per annum, which versus closer to $100,000 in other high-income countries. CT scans cost more than double in the US, as do MRIs, colonoscopies, and a host of other procedures. The price difference between the US and other countries even gets covered in stories that get featured everywhere, from the National Enquirer to The Economist. When Prince William and Kate Middleton, the Duke and Duchess of Cambridge, had their baby, the royal baby was delivered in what The Economist called a luxurious private maternity ward in London. Now, the cost of delivering a baby in a luxurious private maternity ward in London, $8,900. I live in London, and I can personally vouch that it is not a cheap city. What do you think the average cost for a normal delivery of a healthy baby is in the US? The Economist reported $10,800. In some communities, it's arguably much more. Now, when it is cheaper to deliver the royal baby in a luxurious private maternity ward in London than it is to deliver a healthy baby in the United States, we have a price problem. But high prices need to be understood in the context of what that price buys. In some instances, higher prices in the US do mean Americans will get access to the latest medical devices and medicines more quickly. But that is not always the case. High price does not always mean higher quality. MRI machines in Geneva are every bit as good as those in Boston, but the US price is 3 times as high. And this price disparity holds true for almost every category of medical good and service that we could find data for. But let me tell you, finding price data in healthcare is difficult. And that points to another reason why healthcare costs are high. It is easier for sellers to charge higher prices when buyers cannot find out what the prices are. Now, when I look back at the results of our study, I have to admit that some of the findings really surprised me. I was shocked to learn that the US spends more per capita on social programs than countries like Canada and Australia. And this was also one of the findings that we got the most feedback on. Many people strongly believe that social spending drives healthcare spending, or at least that it strongly influences it. And when you show data that suggests otherwise, some people think what you're saying is social spending isn't worth it. But that is not at all what I believe, and it's not what the data suggest. Personally, I support robust social spending on things like education, housing, and family care. They're important because they improve health outcomes, and indeed, social outcomes. But we should invest in social programs because we care about society, not because we think it will lower healthcare costs. The data suggests otherwise. So where does this leave us? If we can't get control of healthcare costs by investing more in social programs, or by pushing for less utilization, or by producing more primary care physicians, what can we do? What will actually work to curb healthcare spending? Based on our research, here's how we diagnose the problem. The US healthcare system is deeply dysfunctional for 3 main reasons. First, lack of data on prices and lack of cost transparency. Second, decreasing competition with little price regulation. And third, a system that is fragmented and administratively complex. At least we know this much. When it comes to US healthcare, we're all entitled to our own opinion, and sometimes we can even agree on certain facts. No single study has all the answer, and there will always be new studies with new facts. But when you compare the US to other countries, one fact comes into sharp relief. The US healthcare system today is on an unsustainable trajectory. But at the same time, I believe we are starting to see 3 fundamental prescriptions for the problems of price, decreasing competitiveness, and administrative inefficiency. The first prescription is about encouraging real price transparency in healthcare for patients and providers. Buyers in any other industry wouldn't tolerate blank price tags, and there's no reason why they should tolerate it in healthcare. The second prescription goes out to US government agencies like the FTC and the Department of Justice, and it's about enforcing antitrust laws in healthcare. For example, hospital mergers are on the rise. Fewer providers means less competition. Less competition with little price regulation and little price transparency means high prices that keep rising. The third prescription is about improving administrative efficiency. There's a lot of low-hanging fruit here, such as billing that's smarter and faster and streamlining the credentialing process. When the US healthcare system becomes more efficient, wasting less on administration, and with more price transparency, we will go a long way towards having a system that's more rational and sustainable that we and future generations can live with. So is that a fact or an opinion? I leave that up to you.